The Tokyo Guidelines 2018, Management of Acute Cholecystitis. Welcome to today's episode, where we delve into the Tokyo Guidelines 2018 for managing acute cholecystitis. These internationally recognized recommendations set the standard for diagnosing, grading severity, and determining the optimal treatment for this potentially serious condition. Whether you're a medical student, a practicing clinician, or simply curious about how evidence-based medicine guides care, this discussion will walk you through every step in a clear, methodical fashion. Diagnostic criteria. According to the Tokyo Guidelines, to establish a diagnosis of acute cholecystitis, the guidelines require that three elements are present together: at least one local sign or symptom of inflammation, at least one systemic indicator, and supportive findings on imaging. Let's break down these elements. First, local signs include tenderness or pain in the right upper quadrant of the abdomen, a palpable mass in the same area, or a positive Murphy's sign, which is a specific physical exam finding. Second, systemic indicators may involve fever, an elevated C-reactive protein level, or an increased white blood cell count, all suggestive of an active inflammatory process. Third, imaging plays a supporting role. Ultrasound may reveal a thickened gallbladder wall, pericholecystic fluid, or a distended gallbladder. Computed tomography or magnetic resonance imaging may show wall enhancement, pericholecystic fluid, or changes in the surrounding fat. All three elements, one local sign, one systemic sign, and imaging confirmation, must be present for a definitive diagnosis according to the Tokyo Guidelines. Severity grading. Why it matters. Once the diagnosis is clear, the next step is to assess the severity. The guidelines classify acute cholecystitis into three grades: mild, moderate, and severe. This grading is crucial because the management strategy depends greatly on the severity. Mild cases describe patients who are otherwise healthy and show minimal inflammation. These individuals typically respond well to initial medical therapy. Moderate cases include those who present with more pronounced symptoms, such as a significantly elevated white blood cell count, a palpable tender mass in the right upper quadrant, or symptoms that have lasted more than 72 hours. Marked local inflammation, such as gangrenous cholecystitis, abscess formation, or peritonitis, also fits this category. Severe cases are defined by the presence of organ dysfunction in one or more systems. These may include cardiovascular, neurological, respiratory, renal, hepatic, or hematological compromise. Treatment strategies tailored by severity. All patients, regardless of severity, should receive initial supportive care. This includes keeping the patient fasting, administering intravenous fluids, and providing pain relief. Early administration of appropriate antibiotics targeting common pathogens such as Escherichia coli, Klebsiella species, and Bacteroides species is also essential. For mild cases, early laparoscopic gallbladder removal is considered the gold standard. Surgery should occur during the initial hospitalization and ideally within the first week after symptom onset, once the patient is adequately stabilized. In moderate cases, the timing and approach to surgery require careful consideration. Early laparoscopic removal is still preferred when performed by experienced surgeons in properly equipped facilities. In situations with significant inflammation, a partial gallbladder removal, known as subtotal cholecystectomy, may be safer to avoid injury to the bile duct. If the patient is unstable or the surgical team lacks experience in complex cases, initial medical therapy followed by delayed surgery after 6 to 8 weeks is an acceptable alternative. Percutaneous gallbladder drainage may be used as a bridge to definitive treatment. For severe cholecystitis, where organ dysfunction is present, the primary goal is stabilizing the patient and managing the underlying sepsis. Immediate surgery is not recommended. Instead, initial medical therapy and organ support in an intensive care setting take precedence. Gallbladder drainage through percutaneous intervention is the preferred initial procedure to control infection in critically ill individuals. Once the patient's condition improves and organ dysfunction resolves, delayed surgery can be considered weeks later. For some high-risk individuals, gallbladder drainage may remain the definitive solution. Recent updates and emphases in the Tokyo Guidelines. The 2018 guidelines clarify several important changes. The role of percutaneous gallbladder drainage is emphasized, especially for patients with severe disease and for some moderate cases who may not be suitable for surgery. Subtotal cholecystectomy is highlighted as a vital option to avoid bile duct injury during difficult or inflamed procedures, particularly in moderate cases. The guidelines also stress the importance of starting antibiotics early and note that these can often be discontinued within 4 to 7 days if the infection source is fully controlled, such as after gallbladder removal. Finally, a multidisciplinary approach is strongly encouraged, with collaboration among specialists in intensive care, interventional radiology, and surgery, especially for cases graded as moderate or severe. Thank you for joining us for this comprehensive journey through the Tokyo Guidelines for Acute Cholecystitis. If you found this episode informative, please subscribe and stay tuned for more surgical insights. Until next time, it's the Everything Surgery Podcast. Dissect the extraordinary.